side effects, right? And ultimately, it's to facilitate the important milestones, the achievement of important milestones, which is early mobilization and early oral feeding. All right, and here we are guided by this very comprehensive website run by the ERAS Society. That's the address over there, right? So when you look at this website, you have lots of guidelines, and for a variety of surgeries, okay, starting from gynae, GIT being the forefront of the thing. And along the way, they have developed guidelines for gastrectomy, cystectomy, even breast and reconstructive surgeries as well, right? So the purpose of me being here today is not to tell you what's right, what's wrong, just to remind you, actually you know a lot of things. You do, right? I'm just here to remind, reinforce, review, reappraise, restore, be a bit realistic in certain things. Sometimes, we all come from different centers with different abilities, and our staffing is very different, right? Probably you would like to rebut, but, all in all, I hope to facilitate and maybe, share some of my experience. And in return, I'm hoping you could share some of your experiences with me as well, right? So, as I mentioned earlier, one of the pioneers of ERAS was actually the GI surgery people, as how Mr. Howe and Dr. Jonathan and Paul had mentioned earlier. So, and they had come up with this very, I would say, very elegant guideline, which is divided into two parts. I think you've seen this one too many times already, right? And in this guideline, they had divided it into pre, intra, and post-operative, and you would find that actually there's quite a bit of emphasis on pain management, okay? And this is how the guideline looks. It looks very daunting, very challenging, but I think maybe if you were to approach it in a case-based approach, probably, you would realize that actually it's not very difficult, and probably you've done a lot of this on your own yourself. So here I present to you is the GIT. Okay, he's 68-year-old male. He has CA rectum. He's planned for laparoscopic low anterior resection surgery. He's a former chronic smoker, right? He has COAD and he's on medications, right? He's hypertensive. He's dyslipidemic. He has prostatism, right? And OA. Sounds like your regular patient. Don't you all see these kind of patients, right, in your day-to-day practice? Huh? So nothing special, okay, about this guy. So only thing he's going for this, and you're going to try to improve the pain management in him, right? So the guideline says start out with risk assessment, right? Okay, and followed by preoperative optimization, which is important in pain management, right? So we start nowadays. We see a lot of our patients in anesthetic clinic, right? And so pain management starts there itself, okay, where you optimize the medical condition. Advise Mr. GIT to stop smoking, stop taking alcohol, whether he listens to you or not, different matter lah, right? So then anesthesia clinic is not just about anesthetists, right? It's also run by the other therapists, the physiotherapists who will be teaching Mr. GIT on deep breathing exercises, chest physio, and incentive spirometry, which he will be doing later, post-operatively. The occupational therapist will advise upon TB stockings, and the pharmacist will go into details perioperative medication counseling, right? And we'll be able to answer any of these queries on post-op medication as well, right? So in line with the ERAS guideline, he will not require any opioid or sedative medications on the morning of surgery. Antihypertensives will be served to Mr. GIT, right? And we will continue oral medications and MDI nebulizers for his COAD right up to the time of surgery. Okay. He will be near per oral from 12 midnight to 2 a.m. to be allowed sips of clear fluids and preoperative carbohydrate loading as per surgeon consultation, right? Okay. Being good anesthetists, we will prevent awareness and minimal side effects. Okay, we will be guided by the MAC of 0.7 to 1.3 and using BIS as well. So yeah, it's true, we should be using BIS for most of our patients, not just TIVA and all that. So if you use volatile anesthetics, you could use our BIS, right? Okay, so post-op nausea and vomiting is very important in pain management. Okay, so perhaps we could give any of these 2 out of 3 ain't bad. Okay, so you could give Dexa, granicytrone, Maxlon, metoclopramide. Okay, you want to use TIVA. Okay, sure, no problem. Here's another thing you can consider. Okay, in our center we use acupuncture in part of our pain management, so we could actually use acupuncture at the 2 points here, right? PC6, alright, that's what we normally use, and then we could use the auricular one, which is normally not commonly used. Okay, so this would be a more scientifically, lots of literature on this for post-op nausea vomiting. So things to be considered for post-op nausea vomiting. Alright, so we will pre-oxygenate as normal, preoperatively, and then we will keep the FiO2 within acceptable limits, right? These are the acceptable limits. Maintain an adequate depth of surgery, monitor neuromuscular blockade, and reverse as per TOF ratio or TOF4. We will institute good warming practices. These are the devices that we always use in our centers. Okay, I'm sure we are all very familiar with this, right? And in line with the ERAS guidelines, we will not be routinely inserting nasogastric tubes, Ryle's tubes, and we can consider doing it if there is going to be a problem in post-operative delayed gastric emptying. Okay. Sugar control is very important. Good sugar control, regular monitoring, and perioperative insulin therapy. And as what Paul said just now, goal-directed fluid therapy. So that's part 1, and part 2 of ERAS is actually for anesthesia practice. Okay, so this is where it becomes more exciting. Alright, so where pain management is concerned, the ERAS guidelines for GI surgery recommends with strong evidence thoracic epidural anesthesia. Okay, and the evidences for the other modalities like intravenous lignocaine infusion and tap locks seem to be very compelling as well. They are moderate. Okay, and for continuous wound infiltration, it seems weak for the time being. But in the case of our Mr. GIT, who's going for laparoscopic, okay, what the evidence says is that TEA is weak, epidural, okay, but we still have options. We have the local infusion, local anesthetic infusion, intrathecal morphine, if you choose to give, or even tap blocks, the transverse abdominis plane blocks. Okay. I know post-operative delirium was discussed just now, but my purpose of bringing this up is to tell you that adequate pain relief and the limited use of benzodiazepines helps with post-operative delirium. So your pain management method will influence the post-operative delirium as well. Okay. You can't avoid but to have post-operative ideas. Why? Because it is GIT. It's a GIT surgery. Whether you like it or not, there will be somatic and visible trauma, there'll be gut handling and anastomosis. Of course, the longer you handle, the more problems you have. And then along the way, we give fluids, we give opioid analgesia, and through a spectrum of activities, you'll end up in post-operative ideas somehow or other. Okay, and the consequences can be varying. It could be nausea, vomiting, could be distension, it could be absolute constipation as well. So in line with that, we are supposed to treat post-op ileus in a multimodal manner. Alright. Here are the risk factors that present in a patient with primary post-operative ileus. Okay. Other than the normal patient factors, which is male with the respiratory disease, peripheral vascular disease, you also actually have intraoperative risk factors, okay, and strategies. So you could intraoperatively give the thoracic epidural analgesia and give opioid sparing strategies like lignocaine, NSAIDs, COX-2 inhibitors, and caffeine. Post-operatively, you can continue doing the same thing, and when it actually in centers where it's available, you could give the opioid antagonist, Mopar and methyltrexone. I'm not sure whether any of you are familiar because
No, we don't have it in Singapore.
Yeah.
And it's very expensive.
Actually, the literature from US says that it's what, 20 US per dose or something like that.
Apparently, 12 doses will cost about $2,000.
Same.
Yeah.
Okay, no need to.
At least you guys have chewing gum.
Okay, yeah, we have chewing gum. Yeah, I wanted to tell you that. The chewing gum is there.
Yeah.
What brand? Up to you. Okay. So, to summarize, the post-operative ideas, strategies, the pain management part is actually quite important. So, you know, when you use IV lidocaine, it's anti-inflammatory, opioid sparing, that's good. Okay, when you use NSAIDs, okay, again opioid sparing, right? You use thoracic epidural, that means thoracic epidural, okay, you get rid of all these other things. It antagonizes the immune receptor, decreases inflammatory response, you know, and decreases opioid requirement. And then you have the magnesium sulfate infusion, which is also co-anesthetic effect as well, right? In final stage, you have this early mobilization thing, which is, you know, that is our aim. We want to mobilize and let our patient eat faster, isn't it? So you have a multidisciplinary physical activity program, and who runs this program? Lots of people. Actually, basically part of the ERAS team. It's basically a team effort with the physiotherapist, occupational therapist, nurse, dietitian, pain management team, anesthetic surgeon, hospital management. Nothing works without the bosses, right? So audit team as well. Okay, so audit is very important in ERAS, and so the audit team is there. Right. So coming to multimodal analgesia, probably heard this word many times, right? And actually, the aim is to control pain at different classes of medication acting on different sites, to improve post-op pain management, reduce surgical stress, attenuate multi-organ dysfunction, reduce opioid side effects, early resumption of oral diet, early mobilization, and accelerate surgical recovery. So these are our aims. Right. How to do it? Very simple. Okay, go at every step of the way. All right, use whatever you can use. NSAIDs, COX-2 inhibitors, you know, all along the pain pathway, there are many ways to do it. From the nociceptor right up to the brain. Okay. So coming to the gold standard, which is the thoracic epidural analgesia and GIT. Yeah? It seems to be the gold standard, and it actually has a grade 1 evidence in open abdominal surgeries, as well as laparoscopic assisted major abdominal surgeries as well. Here is moderate. Okay. So compared to parenteral opioids, the epidural blockade has shown to provide better post-operative analgesia for at least the first 3 days, right? So you can accelerate the recovery of GI function, right? Because it blocks the nerves and prevents gut paralysis. Prevents the increase of circulatory counter-regulatory hormones, which means it reduces insulin resistance, sugar control will be better, there will be less catabolism and less hyperglycemia going on. So it impacts positively on cardiovascular and respiratory complications. Your patient actually can be easily rehabilitated, right? It's an early mobilization, they get out of bed better because the pain management is good, and of course it's opioid sparing. But one of the potential drawbacks is actually not all patients can have epidural done to them, isn't it? Okay, some are they are contraindicated no matter what the reason is, and there's always the risk of having a sympathetic block, dealing with the hypotension, and part of it is actually giving a lot of fluids. Okay, so you wouldn't want to give a lot of fluids and load your patient, so that's one of the risks you face with this thoracic epidural analgesia. Urinary retention and pruritus is a common side effect as well. So apart from thoracic epidural analgesia, you also have the intrathecal analgesia, a very humble technique, it's a very old technique, but it's very significant in reducing and aiding in our ERAS aims, okay? Not without its side effects as well. It's the most notorious one is actually pruritus, and then dealing with it is very, very difficult sometimes, okay? It gives a lot of post-operative urinary retention and opioid-induced ventilatory impairment, okay, if you were to have in certain patients as well. So sometimes, you know, one wonders whether other regional anesthesia techniques would be more favored, especially in elderly patients. So maybe with elderly patients, you would like to go easy on this intrathecal morphine, maybe, probably not, right? But whatever it is a technique to shorten hospital stay with ERAS protocol in low-risk patients, right? If you notice, lignocaine has sort of like made a comeback in many, many ways, right? And lignocaine seems to be a very versatile drug in pain management here because it can be given in many, many forms. Here we have lignocaine as an option to be given intravenously. It is anti-nociceptive, anti-hyperalgesic, and anti-inflammatory. So the systemic administration of IVL, okay, intravenous lignocaine infusion, has been shown to improve post-operative analgesia and fulfill our ERAS goals. Okay. You can actually give local anesthetics all along the pain pathway, if you notice. And how we would give? The recommendation is to give a loading dose of 1.5 to 2 milligrams per kilo body weight, about 30 minutes before or during induction. Maintain it at about this dose, and you can even continue it post-operatively for the next 1 to 2 days. Right? There are lots of guidelines. Lots of hospitals use different guidelines. Some will even use a lesser dose, 40 miles per kilo per weight, so body weight, right? Continue it with PACU and then go on to post-op day 1 and post-op day 2. Right? Contraindications include bradycardia, cardiac conduction abnormalities, heart failure, hypovolemia, liver diseases, and of course allergy to the local anesthetic. So apart from giving it IV, of course you may give it locally, right there at the surgical site, and that too you have different ways of doing it. So these are the common local anesthetic infusion techniques that have been described. One of them is the continuous wound infusion. Not infection. Oh dear. Like I'm showing some sort of bias here already. Okay, so in open abdominal surgeries, it improves post-operative analgesia, and but the effect on recovery of bowel function remains unclear. So I'm not sure how the surgeons feel about this, right? And there are many ways to give wound infusion techniques. Okay, it could be pre-peritoneal, it could be subfacial, and suprafacial. Studies show that the anatomical location with optimal recovery still is undetermined. So maybe that's why there's still a lot needs to be learned about this technique. Whatever said and done, systemic opioids are still required for systemic pain, right? Controlled visceral pain. Another method is intraperitoneal. Okay, so this intraperitoneal mostly the surgeons will do. All right, it's quite good, both for open as well as laparoscopic surgery, right? And a new thing that is beginning to make a trend here, it's the abdominal trunk blocks, namely the transverse abdominis plane block and the rectus sheath block. The beauty is this tab block can be also done by anesthetists as well as the surgeons, okay, before they close the abdominal wall. And there have been many cases where they've actually reported reduction in opioid side effects as nausea, vomiting, sedation, in addition to good pain control. Okay, so this is the approach for tab block, a little bit posterior, and the rectus sheath, normally subumbilical and in the midline. Yeah. Okay, so similar benefits are reported for laparoscopic procedures in context with the ERAS program. It helps a lot with facilitating early discharge, but systemic opioids still needed. Okay. So maybe we need to do more studies, we need to read more, to find out, to validate the efficacy of the tab blocks. But I think my colleagues in the regional anesthesia group are very, very into this, and they are very active in this tab blocks as well. We do a lot of it for chronic abdominal pains as well. Yeah. Okay, so that is the case discussion on GI surgeries. And coming to gynae oncology, you will find actually another very good ERAS recommendation, which is divided into part 1 preoperatively and part 2 postoperatively. Okay, it looks like this. And we have a patient, we were to have a common patient like this, 65 years old, going for TAPSO, having hypertension, has diabetes. How would we approach? You find that it's almost the same like how you approach a GIT patient. Okay, preoperative counseling, right? Seen by physiotherapy, seen by pharmacies, right? No opioid medication, no sedative pre-medication. Omit your diabetic drugs. Okay, start the antihypertensives early in the the surgery, right? The thing is, you give VTE prophylaxis in a lot of these gynae onco surgeries. Okay, it could be heparin, all right, or it could be Clexane, depending on the indication or the preference by the surgeon, right? You put on the TD stockings intraoperatively, right? And the standard anesthetic protocol would be TEA together with the GA, right? And the GA would be short-acting anesthetic of fentanyl, propofol, rocuronium, ketamine, lignocaine, Dexa, and granisetron. Right? If Madam GYN were to go for vaginal hysterectomy, we would consider doing it purely under regional. Yeah, it could be a epidural analgesia with paracervical nerve block, or it could even be your humble intrathecal technique. Okay, depending on your comfort level and the surgeon's comfort level as well. Okay. Post-operative nausea, vomiting is about the same as GIT. Okay, you have your list of drugs that you can consider, right? No need for nasogastric tube. Okay, you want to put the nasogastric tube, take it out before reversing. Right, warm the patient properly. Use a core temperature probe. Right, goal-directed fluid therapy. Not too much, less is more. Okay, and then you have part 2. So in part 2, what happens is in the ward. Okay, you continue to use the stockings. The patient was wearing the stockings intra-op. Continue, right? You may need to continue your subcut heparin and Clexane up to even up to 28 days, depending on the surgeon's indication, right? Try to limit the IV fluids within 24 hours post-op, okay? Because patient can take already after that. Monitor your sugar properly, right? And in the case of post-op analgesia, if your patient has been given epidural, do continue your epidural infusion, right? Alright, and in the case of a hysterectomy patient, hopefully the intrathecal morphine will give good analgesia for the next 24 hours at least. Here's where you introduce another form of multimodal approach, which is using oral analgesics. Okay, and what you would like to use are these 3 drugs. You could consider them. Okay, and how you would give them? You could give PCM, Celebrex, Toricoxib. Okay, for some reason, if you still want to give IV, you could use IV ketorolac, paracoxib, alright, in this dose. And you can actually use the alpha-2 delta ligands, which are the gabapentin and pregabalin as well. Okay, to complete the ward management, alright, peritoneal drainage is not required. There are no wires and tubes hanging out from our patient, alright, so no need for drainage tube. Take out the CBD less than 24 hours within 1 day of surgery and get the patient out of bed at the same time. How to do that? Same thing. You have your expert team over here, right? And it's multidisciplinary. Okay. So I've done the typical cases. So now I'm going to go into this chronic opioid usage patient. You may actually see a lot of these patients, okay? And here I'm going to put a very thought-provoking slide. Do we induce addiction? Do we as anesthetists induce addiction? Anesthetists, no? Yeah, that's what I said. But you know, in this study done in 2010, they found that almost 50% of opioid-naive patients were discharged from hospital with a prescription. So that means they go back with a packet of drugs, okay? They go back with narcotics, right? And you know, the thing is, 3.1% of them get these things for more than 90 days, more than 3 months, they continue with these opioids. And some of them are very strong opioids, compared to 6.1% for chronic non-cancer pain. So actually, I'm not saying that it's happening here. Actually, these are practices happening in North America. So which is why they are answering the question for opioid crisis today. We are not facing that problem yet. I hope we never face this problem. I think it's because of our stringent laws and our stringent practices. So good for us. Yeah. So the thing is, a lot of these patients who go with these drugs, the danger part is that there are a lot of, in this vulnerable group, they are young, okay, they're poor, right, lower social income, household income, they've got a lot of other medical problems as well, they're diabetics, heart failure, respiratory diseases, and they also have substance abuse issues as well. Okay? And here's where we face this problem. Okay, so a lot of us see a lot of chronic pain patients. We treat a lot of chronic pain patients. Lots of chronic pain patients come to us for surgery. All right, you'll be surprised to see there's actually a high incidence of chronic pain based on all the surgeries, and these are the ones that have been studied. What about the ones that have not been studied? You'll probably see more. So we'll be treating, and we'll also be subsequently giving rise to chronic pain patients as well. So I give you Mr. GIAN. Right? Yes. Actually, people ask me what is Gian. Gian actually means withdrawal in Malay, So hopefully, which he will not be having. He's 54 years old, right? He has chronic neuropathic pain, which is of low back and radicular in origin, right? He has major depressive disorder. Ever since he went for a lumbar spine instrumentation 10 years ago, right? And he's on pain clinic follow-up, and he's on the following package of drugs here, of which the top one would be the transdermal buprenorphine patch, Sovino. Are you familiar with Sovino? Sovino is opioid agonist antagonist, right? And the patch here is placed in the top half of the thoracic space, and it lasts for 1 week. So you use a Sovino patch, you change a Sovino patch every week. It's a chronic opioid therapy, right? Initially started for cancer pain, and then subsequently we've started using it for chronic pain as well. So no surprise, when you have patients coming like this, they have a patch over here. So apart from that, he's on gabapentin, duloxetine, paracetamol, baclofen, and LMS, methyl salicylate local application. What happened is he fell at home, okay, had an IT fracture, and now the orthopedic surgeons want to do a PFM for him. Okay, so he weighs 70 kilos and he's 165 centimeters tall. So how to approach this patient? Okay, so some of you may have managed a patient on transdermal buprenorphine, maybe now, maybe later, maybe never. But the worry about buprenorphine and all these strong opioids is the half-life is long, and because it is actually an agonist antagonist, you wonder whether the analgesic effect is adequate or not. So the first reflex for a lot of anesthetists is actually take it out. Okay, because why we are going to give something better? We're going to give opioids or something like that. But I say don't do it. Why? Because it's easier to deal with suboptimal analgesia than to deal with high risk of chronic opioid use disorder relapse. Okay? Because when they are used to some drug and then sudden opioid change, and then after that it'll be difficult to manage the patient. So what we can do is actually practice a little bit of opioid-free analgesia, okay, and anesthesia, and guided by the ERAS protocol for orthopedic. Okay, so no fear, we'll follow step by step, right? And this time the preoperative counseling involves the pain specialist. Okay, I'm not happy to say sometimes the chronic pain patient's favorite doctor. Okay, so you have no choice. You have to co-manage with the anesthetist. We continue the current pain management medications. We are very clear about our goals and expectations with our chronic pain patients. We tell them that you live with chronic pain. There's no such thing as pain score 0. In fact, when we tell our post-op non-chronic pain patients, we tell them pain score of 4 and less is good enough. So that the limit is raised with a chronic pain patient. If you live with a pain score of 6, 6 is your baseline. Okay, let's aim for 6 and below. Okay, so we are very realistic. We never promise our chronic pain patients that just because you're going for surgery, there's going to be like no pain, there's no such thing. And we are very, very clear about this fact. Current opioid dosages will be maintained, but not increased. Okay, so there are some rules and regulations which you need to discuss with your patients, your chronic pain patients, right? Okay. So, having said that, we will continue with the regular analgesia, all right? His usual package over here, right? And we will try to use this pain pathway all along the way. Okay. So we spoke about these drugs just now, so now it's time for us to try these drugs as well. Okay, so gabapentin is helpful because the usage of preoperative gabapentin significantly reduces post-operative opioid consumption in line with our ERAS aspirations. Okay, and what we will do is, since we cannot do epidural, we cannot do spinal, so that's out of the question. Maybe we can try using ultrasound guided spinal anesthesia. That's for the brave. Okay, those who have done can do. All right. Those who have help from the original anesthesia colleagues can maybe try a lumbar plexus plug without continuous infusion catheter. You could try a sciatic nerve block, single shot, or with a catheter, depending on your experience, depending on your facility, right? Okay. But for those who opt for the general anesthesia technique, which I think perhaps I would do too, all right? Probably you have to consider the opioid-free anesthesia or the opioid-low anesthesia, okay? Which involves lignocaine infusion, magnesium, ketamine, or let me introduce to you the Bruges protocol. Okay. All right. So here we are using the continuous infusion lumbar plexus block, all right? And we give this analgesia, all right? And we can actually give this infusion also at the same time. Okay. Just a special mention about paracoxib in terms of orthopedic patients. And this was from the European Journal or Orthopedic Journal in 2014. It's especially useful in orthopedic patients because they consume significantly less morphine, have a reduced pain score, significantly lower pain movement score also, right? And the interleukin-6 and prostaglandins in the joint fluid have significantly low concentration after paracoxib. So you can consider using that for your post-op patients, right? Early mobilization is important, and here you are again, bombarding you with that same thing. Okay, so this is the Bruges protocol, all right? Dr. Jan Moulier in Belgium, he had come up with this protocol, and what he did was post-operatively in a 1 liter saline package, okay, he had put in 100 milligrams of ketamine, 100 micrograms of dex, lignocaine and magnesium sulfate, and he proposes that you run it for 12 mils per hour. Okay, so this is helpful in opioid sparing techniques as well. Last but not least is the bariatric surgery. Thank you. Here we have Madam GUT, Madam Gut, right? She's 42 years old. She's planned for laparoscopic sleeve gastrectomy. Why? Because she's 105 kilos, right? Ideally, she should be 55 kilos, right? She's 160 centimeters tall, and her BMI makes her 39.5, right? She's diabetic. She has all the packages of a bariatric patient. She's diabetic. She's hypertensive. She's dyslipidemic. If you want, you can throw in a thyroid problem as well. Okay. Good for her. She has no allergies. Good for us also. Yeah. She has undergone a past surgical history of a bilateral tubal ligation 5 years ago. Socially, she's married with 3 children, works as an accounts clerk as a dispatch firm, was active in sports during the good old days. I guess not anymore. Okay, so she snores, but with no daytime somnolence. And based on the stop bag, she's actually an intermediate risk of 3 to 4. Right. On examination, she has her air is pretty okay actually. She's Malapati 2, lungs good, cardiac okay, and blood workup and ECG checks, X-rays are all okay. Sleep study is AHI is 15, which makes her mild to moderate, okay, for OSA. So here we have the guideline for bariatric surgery, another very good comprehensive guideline. It's very detailed, okay, very explicit actually. It starts with pre-operative information, counseling, rehabilitation exercise, weight loss, which I find I was very surprised to see that rehabilitation exercise being very low in evidence. So you can't tell, if you tell a patient to exercise, the evidence actually says it's very weak actually. So probably more studies need to be done. Okay. So post-op nausea vomiting is very important, all right. same thing for your patients, same steps that you can institute. You have the standard anesthesia protocol, okay? But the current evidence shows that there's no specific anesthetic agents or techniques. So which is why I'm going to show you something which you might like to consider. Alright, and post-op analgesia also is not very specific either. Okay. So there are lots of techniques on how people manage bariatric anesthesia and analgesia. Let me show you one from Hong Kong. There's no right and wrong. You know, in this, you find out along the way in ERAS technique, there's just no right and wrong. It's what you're comfortable with, and it's, you know, you're guided by these guidelines. So in this hospital in Hong Kong, they gave a pre-med of Panadol and pregabalin induced, you know, with the standard, and intraoperatively gave ketamine, paracoxib, tramadol, local anesthetic infusion. And then they have this thing where they rescue analgesia, and surprise, surprise, they give pethidine. So, you know, but it works for them, okay? So, and they give pethidine here, they give pethidine in the ward. You can even rescue pethidine every 4 hours. Right? Wrong? Depends on what works for you, what works for your patient. But of course, once the word pethidine goes in, you know, it strings up a lot of emotions. So, you know, yeah, we're not in favor of pethidine, so let's forget about this. Right. Let's talk instead about this opioid-free anesthesia. Okay, opioid-free. So opioid-free anesthesia means no opioids used intraoperatively till end of surgery. So what to use? You use the regional anesthetic techniques, okay, using local anesthesia, alpha-2 agonists, ketamine, magnesium, to achieve stress-free anesthesia, stable hemodynamics. When I say stress-free, not just for the patient, no, for the anesthetist as well. Okay. So let's say, you know, no choice, and you know you're desperate already, and you know an opioid can be added. Okay, then it will be converted from a OFA to a LOA, or opioid sparing anesthesia. Still okay lah, you won't feel so bad, isn't it? Right? So why do they avoid opioids intraoperatively? Why should they? Because they say that if you use less analgesics required postoperatively, both opioids and non-opioids. Okay, and because of that, when you use less opioids, you have less post-operative side effects of opioids, which are the O group, opioid-induced ventilatory impairment, or opioid obstructive breathing. Okay, the O group, and the P group. Okay, post-op nausea, vomiting, post-op ileus, post-op shivering, post-op urinary retention, and post-op cognitive dysfunction. And then you have the M group. You minimize risk of osteoporosis, minimizing risk of cancer recurrence, and minimizing the risk of chronic pain or addiction. And the indications are many. All right, you could use OFA for narcotic abuse history, all your difficult pain patients. All these side effects of opioids, obesity, obstructive sleep apnea, right? Chronic pain, hyperalgesia, all in line with your ERAS protocol. The absolute contraindications are many, so probably you have to go through and see whether your patient falls in this criteria, right? And some of the contraindications are due to the side effects of the adjuvant drugs, and these are the side effects. Since there are so many drugs, probably have to go and study them. Yeah. There are relative contraindications, okay? And how we give anesthetic drugs is by using lean body weight for some drugs, propofol, rock, paracetamol, lidocaine, and adjusted body weight, which involves 40% extra, okay, propofol and pseudomodex. So here's the Bruges protocol, the one I was telling you what Prof. Jan Mulier was using in Belgium. Okay, so it's a step by step. Okay, it starts 1 hour before anesthesia, where you give the gabapentin or pregabalin, 15 minutes before, during induction, intubation, and maintenance. Okay, so the Bruges protocol actually involves the OFAM mixture, opioid-free anesthesia mixture. Okay, how he uses this is actually he takes a dex of 50 mites, ketamine 50 milligrams, and dilutes it in a syringe up to 50 cc's, and he uses the same thing. So in the case of Madam GUT over there, her induction dose would be 5 mils, maintenance of 5 mils per hour, and post-op 2.5 mils per kilo per hour. Okay, so our Madam GUT, she will have her pregabalin or gabapentin, whichever that you prefer. Okay, you could give your IV dexamethasone 8 milligrams, right? And then when she comes to theatre, 15 minutes before induction, you would start Visidex infusion, 12.5 milligrams, right? And then at the same time, start this OFA mixture to run at over 1 hour. Remember I told you at 7 mils per hour, okay? While you're inducing with a propofol of 2.5 milligrams per kilo. And then when it's time to intubate, you intubate with a rock of 50 milligrams. Right? And then when you maintain, you could either choose to have inhalation or you could have TIVA, okay, guided by their MAC or BIS. Moving along, as the surgery progresses, okay, you can give magnesium sulfate, right, and give anti-inflammatory drugs if needed, right, dexamethasone, NSAID, coxibs, okay, and continue to maintain with that mixture of yours. So in Madam GUT, you would give magnesium 200 milligrams over 15 minutes, DEXA, if you haven't already given, right? Give your ketorolac, your paracoxib, if you, okay, not contraindicated. Maintain with this infusion, right? And when surgery is over, it's time to reverse. And if you reverse the deep block, you could give 4 milligrams per kilo of spermadex, right? Or if it's a shallow block, TOF of 2, you can give 2 milligrams per kilo, right? So this is an example you would like to consider for your patient, right? Just like how you have opioid-free anesthesia, you have opioid-free analgesia post-op, okay? Once again, try not to use opioids at the end of surgery till hospital discharge, till return of normal activity to home, okay? Use instead all these drugs. What are the drugs to use? You continue with your OFA mixture, all right? And post-op, you can use the Panadol, Celebrex, Coxia, Ketorolac, Paracoxib. See, okay? And this would not be a problem for you. Yeah. And of course, the post-operative infusion goes like this. Okay, I think I've said that before. So in summary, the multimodal analgesic technique is for optimal pain control. It is to facilitate achievement of important milestones like tolerance of oral intake and immobilization, to prevent opioid side effects which are dose dependent and which will delay recovery. And if you notice, post-op pain management is very procedure specific. Different surgeries, different styles of doing it. Okay. And the discharge criteria is good pain control with oral analgesia. They take food with no IV fluid requirement. They're independently mobile, or at least same as how they were pre-operatively. They're competent with whatever surgical stoma or whatever catheter that they have now been created for them. They are well supported with regular phone contact from the nurse clinician and have access to a 24-hour emergency phone number. And of course, this must have the confidence of both the patient and the caregiver. So just like that, there are lots of other guidelines. If you go through this website, there are actually guidelines for liver surgery, colonic surgery. Not a battery, I think. Okay, liver and colonic surgery. You have ERAS guidelines for breast reconstruction. You have for head and neck surgery as well. Radical cystectomy, okay, and gastrectomy. Rectal pelvic surgeries and pancreaticoduodenectomy. So many guidelines, but essentially they are about the same. And I think you know how to do it. You just need a reminder. Once again, I thank you for having me, and I'd just like to remind you to come visit Ipoh.